Okay, so thank you, Professor Sender, for inviting me. I think the other thing I wanted to say to Lenny is thank you. I mean, Lenny has been a colleague, a collaborator, but he's also offered many junior clinicians like me mentorship, and I really thank him for that. So today I'm going to be talking about the Australasian experience. I'm an adolescent oncologist, a dual trained. I did adult training and then paediatric oncology training in the TCT centres in the UK, and I've been in Australia for 5 years. So I'm going to talk about the Australian context. We've heard a lot about BFM and European studies, and we've also heard a lot about the American studies. So while I'm going to touch about our AYA ALL studies, I'm also going to talk about some of the psycho-oncology and models of care that are really key to us developing services in Australia. So to start with, just putting it into context, this is some census information. Before we understand our patients and know what to do in terms of clinical trials, we've got to understand who the population is. And in Australia, the AYA, and we define that as 15 to 25, make up 21% of the population. It's almost equal, male, female. The majority of our patients live in the city. Almost half are still living at home. In fact, the average age of leaving home in Australia is 28. And then when you look at census data, they return home at 35. So it's really important to think about these things. Just under a quarter are in the lowest socioeconomic centiles, and unfortunately 50%, even at that age, have credit card and consumer debt, and another quarter are unemployed. So you really have to think about this in the context of providing treatment. So this is Australia. And you'll see that we only have 1,000 young patients, adolescent young adult patients, diagnosed with cancer each year. And that's in a population of 23.5 million people in a geography of 7.7 million kilometres squared. So it really is more likely to be struck by lightning than to have acute lymphoblastic leukemia, the same numbers of patients. So apart from having the 72 most dangerous species of animals, what else is different about Australia? Well, there are a lot of different things in terms of our models of care. So the geographic differences are marked. On average, my patients have to travel 239 kilometres to come and see me, which means they have to travel with quite bad public transport, about 2 to 3 hours. So when you're thinking about providing the best care and getting people to come to centres that have clinical trials, the young people have to believe that it's worth it. And most young people, while they may want to be in AYA centres, they don't always buy into the need to be far away from home and to be then more dependent or interdependent on people, family members, friends who have to come and bring them. We also know that in our rural and regional areas, the supportive care is considerably different, and there's poorer access. And we also know from our registry data that there is lower survival in the socioeconomic areas, which also tends to correlate with rural and regional areas. In Australia, like many of the countries we're going to hear about, there is this difference between paediatric and adult facilities, and models of care that have already been set up. But one of the things we haven't talked about is what is experience and expertise? What do you need to be able to conduct and look after AYA patients? And I think I'm fortunate to have benefited from dual training and adolescent health training, because I think we do really bring not only the medical care for patients, but also the psycho-oncology and the adolescent care that many of these patients need. And I'm going to show some examples of that. When we're setting up models of care, and certainly new models of care, you also have to think about some of the provisions that have already been established and provide very good care already. So the MDT and tumour boards and established referral pathways. And unfortunately, unlike some places, we have no health legislation about place of care, so patients can be treated in any centre. So when we talk about our Indigenous population, Aboriginal and Torres Strait Islander people, the numbers are low. So out of the 120,000 cancer diagnoses a year, only 800 a year are made up of Indigenous populations. And unfortunately, the Indigenous Australians are more likely to be diagnosed with a cancer diagnosis at a younger age and have a higher incidence than non-Indigenous Australians with poorer survivals. But because of the smaller numbers, there haven't been very good studies about individual cancer groups. And as acute lymphoblastic leukemia is not one of the 10 most common cancers, even though the AIHW do present data every 5 years, they haven't actually looked at the ALL data. But this is some data that was from Ross Pinkerton. He was at the Marsden and Nowers in Brisbane. He did a very nice linkage study where he had data from the Australian Cancer Database, which was linked with the cancer registries, the death index, the births, deaths and marriage information and hospital reported outcomes. And you can see, although we haven't got the current data that's just about to be published, when you're talking about incidence, there's very small numbers of patients. So each year we see about 20 to 30, 15 to 19-year-olds, and the same number around of 20 to 29-year-olds. So when you think about running clinical trials in Australia over all those states and with the geography, it makes it very difficult. So how do we do with survival? And again, when you look at the trends as represented in the data that we've seen America and Europe, there's improving survival across the paediatric population, the 15 to 19-year-old population. You can still see from 1995 improving survival. But in the 20 to 29 age group, the 5-year survival is poorer. Now, is this because of access to clinical trials, these patients being treated on paediatric trials? Well, probably not, because the data on paediatric trials started to be produced after 1995. So a lot of this improvement in survival, certainly in the Australian context, was in terms of good supportive care, the streamlining of paediatric centres and transplant centres. So Ross Pinkerton also looked at the data in terms of our colleagues around the world to see whether our survival was poorer. And it's really pleasing to see that despite seeing fewer patients and not being part of big cooperative trials for the older patients, our survivals are still consistent with patients from abroad. So currently our paediatric patients tend to be treated on CHOG studies or BFM studies. And it's just the patients over 16 that we have problems in terms of recruitment onto a clinical trial. So the Australian Leukemia Lymphoma Group, through funding by Canteen, have put together a clinical trial that's based on the BFM. So I'm not really going to talk about this study because we've already heard many examples of trials like this. The only difference with this study is that in addition to collecting the data on survival and transplantation, we're also going to be collecting quality of life data and fertility data. So in terms of a changing practice, what can we offer? And what are the difficulties? Well, certainly the difficulties for us are critical mass, expertise when we're thinking about patients being treated in paediatric and adult cancer centres, the cost, access to clinical trials, access to novel agents if you're not part of those clinical trials, and equity for those patients in rural and regional areas. Some of the ways in which we've been able to deliver studies is have local clinical trials, and although you'll see from our numbers we're only going to be able to recruit very small numbers of patients, that still provides patients with consistency. It allows colleagues to ensure that they have the same expertise that's required to deliver good quality care. There's mandated reporting and governance, which ensures that patients do have good quality care. And we can see an improving standards in the delivery of leukemic care in Australia. We use a hub and spoke model, so I'm going to show you the lead centres for adolescent care. We also have to depend very much on our local colleagues and primary health care providers. And for those patients who come from outside our catchment area, we are dependent on hotel services that are on our campus. So we have Ronald McDonald House Charity and Care by Parent, where patients stay for considerable amounts of time. So I'm going to talk about some of the things that we've worked through in terms of our youth cancer services to try and improve the survival. In 2004, Canteen, which are our advocacy group, worked with Cancer Australia to provide a document called the National Service Development Framework. And that was a document which brought together clinicians, multidisciplinary, to think, what are the things that we need to be able to deliver good quality care for adolescent young adult patients? And they highlighted 6 areas: provision of high quality service, to work on the models of care, to have cohesive MDT teams, to have access for clinical trials and research, and ensure that there is teaching and training of all staff. In 2005, there was a Senate committee, and we were lucky because the senator had melanoma, so he had his own experience with cancer, and he clearly understood that being an adolescent young adult had its differences. And there were 2 really important recommendations. One is that there should be very clear referral pathways, and the second that there should be an establishment of specialist adolescent cancer care units. So then we have the youth cancer services. So Canteen was set up 20 years ago in the hospital that I work at, and initially it was really about advocacy and support. But about 10 years ago, Canteen changed, and in addition to providing advocacy and support, they also moved to being able to provide services. So one of the first things that they did in terms of the submission to the Senate community inquiry was also to put a proposal to government. And we were very fortunate in 2005 to have a promise for $15 million towards the Youth Cancer Service Programme. And in 2009, the funding was awarded, and Canteen's been administrating that. So what's been achieved in this phase? Well, certainly each of the jurisdictions have developed youth cancer services. So there are 5 of these, and these all have a lead clinician, and 4 of the 5 have got a clinician who has dual training. They have specialist nurses, social workers and psychologists, all who have specific adolescent young adult training. But there were additional things that Canteen were also able to see, and they had the foresight to think that young people needed additional things in terms of services. So a postgraduate course was organised for the University of Melbourne that allowed our clinicians within the multidisciplinary team to have training. 2 clinical trials were opened. One was the ALL trial, one was a psychosocial trial. We realised that access to data is going to be really important to be able to prove that these services work, and also look at some of the deficits and successes. So they worked on an AYA national data set, which was trialled in 3 centres between 2010 and 12, and they're currently working on the final data set, which will be a national project. There was a national advisory group and a consumer advisory group, and there were also 3 guidance documents. One was a fertility preservation, one was a psychosocial tool, and one was an early detection GP tool. And during this time, they also worked on establishing age-appropriate information for young adults and for clinicians who are working within both the paediatric and the adult centres. There was also money given to capital works, and we've had the first of our youth cancer services opened in Perth, and the service I run at Sydney Youth Cancer Service at Prince of Wales and Sydney Children's will be the next one, and that's currently being built. In last year, in 2013, on the day that the first centre was launched, we were very fortunate that the Federal Minister for Health at that time, Tanya Plibersek, announced that she was going to give funding for the second phase of the Youth Cancer Service projects and gave $18.2 million. So what's special about these services? Well, I've said, they're cross-appointed services across paediatric and adult campuses. So in my service, there's just a corridor between the paediatric departments and the adult departments. They've allowed us to deliver both tumour-specific and age-appropriate care. They've allowed transition. They've allowed collaboration at centres that have access to research, have access to adolescent care, have access to fertility preservation, and have access to education services. They have also allowed a lot of support. So we have the care navigation that you see across the world with our nurses, psychologists, social workers, really being able to provide the sort of health and support needs that patients need. And we have special educational support for patients. So we know that there are significant barriers for our patients to continue at school, university or vocational training. And even though patients may want to continue, fatigue, anxiety, cognitive and functional deficits stop them from doing this. So all our young people have a school visit or a workplace visit and some education to those people that are trying to provide education and work support for them so they can understand what a young person would need. We also provide careers advice and education support letters for those people applying to do their high school certificate or completing university examinations. So moving on, we recognised that it was going to be really important to collect data on the benefits of these services. So we have a patterns and experience NHMRC study, which I'm CIB on, and this study is going to be running for 5 years. It's a study that is also being done in the Teenage Cancer Trust hospitals, and that their study is called Bright Lights, and the hope is that we're going to be able to put our data together, which finishes around about the same time, and be really able to show some of the important things about Teenage Cancer Trust or youth cancer services. So in terms of the experience of care part of the study, it'll be a cross-section quantitative survey for adolescent young adults. They're going to be completing the survey and then we'll ask them whether they would be happy to complete a survey 12 months later. And we're really looking at the experience, adherence to treatment, and the psychosocial functioning and quality of life. In the patterns of care study, it's a linkage study with the registries and collecting data on demographics, referral pathways, the provisions of care, symptoms. So it's going to be really quite comprehensive. So we've got the services, but how do we let people know that we've got the services in terms of our adult and paediatric adult and paediatric clinicians, and how do we allow patients to choose where they want to be treated based on access to clinical trials. So I developed this AYA clinical trials app, which didn't cost very much. It cost about 6,000 Australian dollars. And this has got all the clinical trials are available for adolescent young adult patients in New South Wales. We update it once a month. We probably spend just under an hour doing this. We send an email each month to our collaborators at the centres and ask for additional information, new trials, suspended trials. And we've been able to show, although we're still collecting information, that this app not only has increased the number of referrals into our centre, but patients are getting to know about where the clinical trials are and coming themselves. And we were lucky to receive a Premier's Award last month for this initiative. We know that 25% of adolescent young adult patients have psychosocial distress that is severe enough that it compromises their quality of life. And in phase 1, Canteen, with the support of adolescent young adult MDT clinicians, developed a AYA-specific psychosocial assessment tool. There's a number of assessment tools that are currently available, but none of them are useful, clinically useful in the context of this age group. So we felt it was better to have something that wasn't validated but had clinical usefulness rather than using one of these things. And in the first stage, what we wanted was a short tool that was like a screening tool, so we could quickly pick up distress that's followed by a more detailed psychosocial assessment. This was implemented in May 2011 after training by Canteen, and it really has been one of the very early and critical successes of our service. So we are able to identify distress early. Most of our patients have a psychosocial assessment within 2 weeks of coming to a service. We have many patients who are not being treated in our service but are referred for the psychosocial support and specifically to have a screening. It's been strongly accepted by clinicians, both adult and paediatric, and although it can be administered by any multidisciplinary colleague, in my service it's been administered by our psychologists, because we've been able to show that the level of distress that we're seeing is so high that there is a high level of patients that need follow-on assessments. Now that is a problem because in terms of the longer assessment, it takes about 2.5 hours of Ursula's time, and then it's one of the really important things is that the person who does it has to write a report, and that report is then sent round to the clinical team, so there is that information sharing, and that's the key difference. So in phase 2, this is a minimal standard for all our youth cancer services, that 75% of all patients have to have a psychosocial screening done. So this is, a copy or half a copy of the screening tool. And you can see it's very easy, just tick the boxes and using the thermometer score the patients. So the next step for us is the validation of this tool, and we're really lucky to be working with Brad Zabrak, Norma Agostina in Canada, and our TCT colleagues to show that this is internationally validated for all populations in different ethnic and psychosocial groups. And we're analysing the use of that with the HADS, the PIED, and the distress thermometers. We're also collecting information about cost and acceptability by both patients and clinicians. So we have demonstrated, certainly in our services, that we can do psychosocial screening, but for those patients who are in rural and regional areas, we wanted to ensure that they could still have access to this. So using telehealth technologies, which we know in our populations are highly computer literate and are connected to the internet, that this could be done. And the study we currently have is using that screening tool in exactly the same way, but there's a randomisation between face-to-face psychosocial screening and telehealth. And we're looking at three things: feasibility, acceptability, and cost-effectiveness. Sticking with the telehealth platforms, we use a lot of telehealth, either using GoToMeeting or WebEx. And Ursula Sampson-Daly, who is the psychologist in our group, and our collaborative team put together her research project, which is part of her PhD, which she submitted on resilience and coping. And this is a study where young patients have 90 minutes of weekly support after treatment, delivered by video conferencing and led by a psychologist. And again, it's another way in which we've been able to reach out to rural and regional patients and ensure that that transition to survivorship can be done in a streamlined way. So I'm going to finish with probably the biggest study that I'm running, which is the fertility study. I think one of the disappointing things is that despite some very large international studies, no one's really looked really clearly at the burden on fertility for our patients. If you think about certainly my patients at 15 to 25, when they come to us, many of them haven't really thought about being a parent. They are too worried about their cancer diagnosis. And if the average age of being a parent is 28 and a half, really these are not things that are front and centre in their mind when they're diagnosed. But you can be sure that it is something that survivors need. And like I said yesterday, at 1 year and at 5 years, infertility or subfertility is the highest unmet need for this patient group. We heard some really, amazing conversations over the last couple of days about treatment strategies. And while there may be no difference in the allogeneic versus hyper-CVAD versus caprese treatments, there is a difference in terms of the fertility preservation outcomes. And yesterday when I went back, I had a look at the hyper-CVAD. There's one very poorly written paper with 25 patients, and unfortunately they were only able to analyse 7 of those. The TKI inhibitor data is all mostly animal models, and we know that many of their patients may be on TKIs for a lot longer period of time, so there's going to be questions about whether they have to come off these drugs if they want to have children in the future, and what's the teratogenic effects, because we know in animal models they are teratogenic. So I've established an Australasian oncofertility registry. It's the first population-based registry in the world, and we were very lucky to have pro bono funding through Salesforce, which is an international IT company, to provide not only the build of the registry but the IT support for 5 years. We have got 53 cancer centres, all the paediatric ones, the youth cancer ones, and are a lead adolescent centres that see most of the AYA patients, and all of the fertility preservation centres in Australia and New Zealand involved. And we're going to be able to collect prospective population-based data on the referral patterns, the strategies, the complications, and the fertility potential following cancer treatment. And specifically, this study has support from a number of tumour groups, and the leukemia lymphoma group was very supportive of ensuring that all the prospective studies they run from now on will include the mandation that the study should collect data on the fertility database. So that's been really good. So to conclude, the national approach in a country which has small numbers of patients has allowed us to provide comprehensive cancer care to many patients. There's still areas that we need to concentrate, and specifically our Aboriginal patients, our rural and regional patients. And there is a challenge in delivering care for complex psychosocial needs of our patients. I think despite the really nice work that Peter Adamson has done with CHOG, it's been very disappointing that adolescent services in many countries have not been able to recruit their patients because of the way in which the Constitution is written. And I'm really hopeful that at some point soon we'll be able to form an international adolescent clinical trials consortium so that we can begin to answer some of these questions. Before I leave, next year we are going to run our own international ALLAYA conference, and I chair this with Pandora Patterson, who's a professor of our research group. We want to invite all our international colleagues to attend. It will be preceded by a youth summit, and I'm sure everyone will not only enjoy the setting of Sydney in the summer, but also, there's some really good speakers. So I thank you all, and I'm happy to take questions.